Now here we have a question that says, following a motor vehicle accident, trauma, a patient with a history of chemotherapy for prostate cancer has a pulmonary contusion and left pneumothorax in which a chest tube has been inserted. Okay, so he got whacked on one side, created a pneumothorax, a contusion, and he's got a chest tube in there. The patient is being mechanically ventilated on volume control using the assist control mode at the following settings. Tidal volume 550. Now we don't have height and weight, so we'll just assume that 550 is reasonable. The set rate is 14, that's reasonable, but notice the exhale tidal volume is only 250, so we've got a big difference between the tidal volume going in and the tidal volume coming back out. That would indicate a leak, probably out through the chest tube over on that side where they had the trauma. FiO2 is 70%, that's significant. If it turns out we need oxygen therapy, instead of raising the FiO2, we would raise the PEEP. PEEP is only 5, and there's certainly room to raise it. Now let's take a look at the blood gas. It says the pH is 7.22, so they have significant acidosis. PCO2 is 54, that's not good. So we have a high CO2, meaning they're not ventilating too good. That's making them acidotic, so it's a respiratory acidosis. The PO2 is only 55, so even though they're on 70%, they're not getting adequate oxygenation. But remember, ventilation comes first. You got to have good ventilation before you can have good oxygenation. And so we got to focus on ventilation with this one. Well, it looks like they're losing a lot of air, probably through the chest tube side where the hole is. And what we need to do is figure out some way to compensate for that leak. So when we come down to the options, letter A says ECMO, ECMO, extracorporeal membrane oxygenation. Well, that's a good way to oxygenate blood, but it's pretty intense, and we don't do that unless it's really like the last possible thing we can try. It's hard to get them off of it once they're on that, and it doesn't really do much for ventilation. It's just kind of taking the place of the lungs. So rather than do that, let's see if we can find something else. Letter B says independent lung ventilation, or ILV. Well, independent lung ventilation is a good idea since we've got trauma on one side but not the other. Then we can isolate the one lung that's bad and has a leak and instead ventilate the good lung, and that should straighten things out for us. So that's going to be the best answer here. APRV and PRVC, these are modes that aren't really going to address the leak issue at all, so they're not going to be helpful. So the best answer is answer B,